Okay, since you both raised the hand, what was missing, which would have been better if he would have said it? That no, the one you raised the hand for. What more to hear? If he would have said that, then would have been better. Yeah. Now, see, there are three laws. The first law, no cantilever. Anybody has a question on no cantilever? Second, there is a question. A lot of times on the lower four, 4 and 5 and 6 are missing, or 4 and 5 is missing, but the mental foramen is exactly where the 4 is and way high. So then you have to give a mesial cantilever. So just because there is a law, for example, we are going to place 2 implants with 6 teeth on top. That means 4 pontics. We are breaking the law, but we are compensating it by longer. So when you do a cantilever, you stick to the mesial cantilever, not distal, and you make sure the implant is strong enough, and you make sure the occlusion is not very heavy on the cantilever. So this is the first law. Second law, canine molar rule. If you have multiple teeth missing, the first option is try to place your implant in the canine and in the molar, and then decide between the other option. The third law is no 3 pontics. 3 pontics, like the beam law from Schillenberg, page number 5, if I'm right. If you remember in 5th year, you studied Schillenberg, or 4th year, some of you. You remember the Schillenberg fixed prosthodontist textbook? Yes. How many times? 3 times. It's a square of 3. So it's 3 and then 9 and then 27. So every pontic you add, the flexibility, it's a cube. The flexibility of the bridge is threefold, cube of 3. Yeah. So 2 pontics, that means already the bridge is flexing at 9 times compared to 3 times compared to nothing as a single crown. Now, when you add a third pontic, the flexibility goes to 27 times. Now, imagine you have a zirconium, imagine you have gold, imagine you have acrylic, imagine you have titanium. They have different modulus. So, who is going to the stress when they want to external or not? The bone around the neck of the implant. So the more you create this flexibility, you are generating stress around the neck of the implant, not here with a knife. 5 is the worst. You are exactly, so it's not very easy. It's number 3. This procedure per implant will take me, say, 30. It's written, the time is written. We will discuss it. Let's multiply, say this will take you 1 hour and 20 minutes surgery. The cost will be this much, okay? The elasticity of the bone in this area is not very hard, is not very soft, so I will not be drilling too much. The drilling that you worried about it, it's not too much drilling. It's worse if it was in the front. Okay? And what all those procedures is not needed. It's a very straightforward case. And that the maximum element, of course, is also does it. That's the immediate. I told you it's number 3. So it's amongst the other cases, you're in the middle. It's not going to be painful, and it's not going to be a zero pain because you're numb. You're not going to. If you enter 1-minute explanation, the patient will immediately take it without even knowing the details, because they know the time, they know the cost, they know where they stand, and they know about the pain. I know they know the procedures. You said there is just an implant procedure. So generally, 5 elements of information. See, with which what I heard, there was only one element, which is the number of implants. It's good, but you cover the time, cost. I know it's plan, but as a general, if you include these 5 elements, normally the will, and he knows that you have thought about 3-dimensionally the whole everything. Yeah, at least we try not to connect. They do fine. A short implant will. Doctor, sorry. Yeah, we have to answer all the side questions before we go today. Those are all those side questions have to be answered. Okay, I hope it doesn't make a noise again. Otherwise, okay, check it out. Okay.
Can you repeat your question again?
Yes. Be louder. Okay. I'm going to ask him to answer you. Go. And wait, and then place the implant, and then wait, and then do the restoration. Okay. Versus, what do you think? Who? Yes. So you are doing a single implant with 9 months of waiting. I'm sure in many continents, this will be acceptable. But in most of the world, people don't have the, see, I don't know how to say that. Yes. Okay, now, see, this is the, okay. Now change the whole dynamic. The level 4 anterior aesthetics, probably with a, most of the time, thin biotype. Now, this is a different scenario. Now, the, the part about the soft tissue healing on top of a socket, if you are using cone, ice cream cone technique, where you place the membrane in a way and you bring it on the occlusal surface of the extraction socket, you do not need to worry about the healing on top. So what is the concept is you can place your membrane on the socket, on the extraction hole, with the graft underneath, because the quality of the membrane is such that it's not just simple collagen. The soft tissue will not, so this part can be eliminated already because of the newer material, not because of the knowledge has changed. The knowledge is still the same. If you use collagen membrane, the collagen will disappear in 3 weeks. The granulation tissue will travel in. All your augmented material are going to be exchanged with granulation tissue, and the osteoclast will eat them away. And if they are HA and the osteoclast cannot eat them away, they will form granulation tissue underneath and push it out of the socket till they keep falling. Or they get trapped inside and will create a granulation material full of bone particles, which is not integrated to your bone. It's just a granulation mass full of bone, artificial, which you put. So these are the 3 things that can happen if you are placing a collagen membrane. But if you place a membrane which is not resorbing quickly, like pericardium, PRF can help on top of the pericardium, but still you need, because how long the PRF will last? 11 days is average. 11 days is going to go. Then if you put only PRF, after 11 days, finished. So you still need to have, or the second option is, what else can last? A titanium mesh. But the problem with titanium mesh, if it's exposed, it will get infected quickly because it has holes in it. One of the recent products, which is very much in use and very much recommendable is, no, we're talking about a membrane. Sorry? Easy Graft is a bone graft that doesn't need a membrane. I'm talking about a membrane material. Placenta. Placenta is an option also with the pericardium. These are the 2 membranes today that you can put it on top of an extraction socket and kind of expect a good prognosis. So this eliminates your 3-week waiting for the soft tissue. If you want to wait for the bone graft to mature, no matter what bone graft you, 3 months is no longer. We are going to 5 and 6 back. We crossed we started with 6-9 months. We made it 5, 4, 3. Some people even went to 2. We saw the failures after 5 years, after 8 years. Now we're going back with the histology, yeah. 5 to 6 months is better prognosis than 3 months, because when you open after 3 months and you drill the augmented bone, you'll find bleeding. You think this is a good news because bleeding means health. In augmented area, bleeding means it's not taken yet. That means it's full of blood supply, it's fully vascularized, but it's not mature. I'll give you an analogy so you cannot forget what I'm saying. Maybe I said this last semester, maybe not. You're familiar with Burj Khalifa? Do you know how many people worked to build Burj Khalifa? So you remember the example. I gave you this example before. 2+. I checked last month. How many people are maintaining Burj Khalifa? Huh? Between 50 and 54 people. If 2,000 plus built and 54 are maintaining it. If you want to take, why did that happen? They finished the work, exactly. And now what they're doing? When you open a wound, the amount of vascularization that comes there is like the 2,000 plus workers. All the vascularity comes in, okay? You have a lot of vessels which are trying to build. Once the bone becomes mature, they disappear, okay? You don't have vessels bleeding in a mature bone. So if you drill an augmented area and you find bleeding, it means you are too early. You have to stop, close, wait. And when you come after 6 months normally, you don't find much bleeding. Should you be worried that this bone is dead? No. This is a mature bone maintaining itself by the natural process of maintaining vascularization, which is not very profuse bleeding when you do the osteotomy. And that's what exactly you want. So I don't know if we answered your question or not. Did we answer the question? Okay. Okay, continuing our discussion in the morning, we have a concavity path for the nerve where if you can benefit from that depression to place a longer implant in the first molar area, look for it and use it. The second issue is the mylohyoid nerve and artery. In the piece of paper that you have, you can easily see the depression of that line. And normally, the area that is concave. So when you place your finger in the patient's mouth and touching the tongue, normally you feel this ridge. After this ridge, the concavity starts. Okay? Now, if you injure that artery, the inferior alveolar nerve bundle, sorry, then what you get is actually the effect is